Hello and welcome to our AN-ACC in Action webinar series, of which today we are covering transitioning pain management under the AN-ACC. And joining me on the call from Mirus, Australia is our Chief Data Scientist, Tyler Fisher, as well as our panel of providers who I'll be introducing to you all shortly. But before we begin, I wanted to acknowledge, in the spirit of reconciliation, Mirus Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Well, the format for our session today will include the following. We're going to work through and specifically discuss a number of items, and I do encourage you all to utilize the Zoom chat function. Post your questions, points of views on the topic, statements, and we'll do our best to incorporate as much of your feedback into our panel discussions on this session and on the topics that we will be covering today. I'll also be sharing insights from the providers, which represent around 35,000 beds across the sector, as they are working through their aged care reform and transformational PMO projects, and the design and specific steps and insights which they are undertaking so that they can implement their new pain management services ahead of the rollout of AN-ACC. We'll also follow up with some of the questions and items that we cannot get to after this webinar. So please continue to engage, and we will have our AN-ACC resources page updated with a lot of that information. So please continue to reach out and keep this conversation alive as we continue to work through this reform. Well, let's begin with our session, and I'd like to pass over to Tyler Fisher to firstly take us through some of the industry and the current state of play with ACFI.
Yeah, thanks, Rob. And I think as I started putting together some of the stats I wanted to point out for this session, it really became apparent what I was doing was sort of compiling an oral history of ACFI. What this chart is showing is Commonwealth expenditure on residential aged care per person over the age of 70. And this is a much broader time frame than just ACFI, but that is what I want to focus on with this chart. So you can see at the introduction of ACFI in 2008, it was followed by a very prolonged flattening of government expenditure. And it wasn't really until around the 2014, 2015 timeframe that that expenditure really started taking off very significantly. But the first thing that this really speaks to is the learning curve associated with a new funding model, and ACFI as a really significant departure from the previous RCS model just meant that the learning curve was much harder to get over. And I think the other sort of interesting thing here is at that point in 2014, 2015, when expenditure really starts taking off, the correlation to claiming patterns and specifically pain management, which we'll see on the next slide, where what that is going to be showing is the percentage of resident ACFIs that contain the complex health procedure of 3, 4A, 4B, or 5. So 3, 4A, and 4B, of course, being different pain management therapies. And procedure 5 forms a bit of, it provides a good frame of reference as one of the other very highly claimed procedures in that domain. And so you can see in the middle there, around the 2014, 2015 period, 4B claiming really accelerating. But I actually want to go back to the beginning of ACFI, where in the very early days, you can see that procedure 3 and 5 are claimed at relatively similar proportions. And I guess what is interesting to note, all the way through the beginning, through 2014-15 time period, is a preference for 4A claiming compared to 4B, where I think what this really shows, that combination of claiming 3 and 5 and 4A, that care is being provided based on a need that's identified in the resident, and that provision of care is what is the basis for the ACC claim. And then as we sort of progress through the years there, and we start to see 4B claiming really accelerate, and one of the things that really contributed to that acceleration was some definitions and terms being changed with regard to OTs and the qualification of a physio that could be used to claim a 4B. But ultimately that acceleration in 4B takes off and really becomes such a key component of claiming in complex health, where that claimable item is what then becomes the basis for how you provide pain management, which seems backwards, where again, the initial claiming patterns we saw was really about fulfilling a care need and then using that to make a claim. And then based on that acceleration that we saw, and calling back to that first slide where Commonwealth expenditure accelerated exponentially, that was obviously something that the Department of Health and the Treasury took very seriously, where at the beginning of 2015, they announced a revision to the complex healthcare domain, which included targeting specifically the pain management items. One of the suggestions was actually reducing the number of points available for 4B, which was ultimately overturned. But what did happen, and you can see as the first phase and the second phase were rolled out on the slide that has the three or the claimable items, in the end of 2016, January 2017, a much more prescriptive application of 4B is enforced. So that's where we get the 20-minute sessions 4 times a week language, and that does have a direct reduction in the claiming of 4B, but it is not very prolonged. I would say that that prescriptive nature of how to deliver a 4B would have caused a lot of allied health contracts to be revisited, where then you can see July 2017, the beginning of a new financial year, the historical trajectory of 4B resumes again. So even through the current claim periods, growth in that the proportion of ACFIs that contain a 4B has been growing month on month. And so again, I think one of the takeaways, and what we'll probably spend quite a bit of time sort of unpacking, is how that strategy and really the language that went into ACFI meant that the claimable item formed the basis for how we provided care. And that's really what we need to unwind. We want to go back to the RCS days, or the beginning of ACFI, where we identified care needs in residents, and that is what we based claims on. And so with AN-ACC, that's precisely what we'll do. You will still use the care need as the basis for how we provide them care, and the resource utilization of residents is what we're funded on. And in that regard, pain management is funded through AN-ACC. And you can further, I guess, extrapolate that thinking in that the Commonwealth expenditure is going to expand by $3 to $5 billion per year over the next 5 years. And based on that alone, any care that's being funded today will be more than compensated under AN-ACC. And I think that's sort of oral history of ACFE and how pain management has played a very key role in the legislation and the changes of ACFE are really a good segue to how we talk about how we transition pain management under AN-ACC.
Now, there's great points on that, Tyler, because I think the audience and everyone recall those days when ACFE did come out, and it was a quite broad statement about the sessions and who could provide it, and it was a general definition of an allied health personnel versus a 4A was an RN or an allied health personnel. And as they lifted that definition and opened it to OTs and even different levels of physios, it really increased then the supply of workforce that could undertake that type of prescriptive nature. But the opportunity from this is really positive under the AN-ACC world, is that we no longer have that prescriptive nature of what and how pain is to be offered through a funding mechanism, which is what was driving effectively these individual strategies or resource allocations to ensure that needs are being met, but also they had to be met within a very prescriptive nature, 4 sessions a week, 80 minutes, et cetera, across that. So great conclusions on that. And I think, a good time series always brings back a little bit of history over our discussion through that. But to build off of that, I wanted to bring into the discussion our panel. We have Dean, Andreas, Sonia, and Siobhan joining us today. And thank you all again, a beautiful panel to joining us, and to open it to you guys specifically. Really, I'll go to you first, Dean, but the question we wanted to really explore, which is on many of the providers' minds, is what was your first concern or reaction when you started to read through and understand the changes of what pain management would look like for your organization under the new AN-ACC?
Yeah, hi. Thanks, Rob. Thanks for the opportunity to join today. Look, I guess for like most providers, when we first started to, I guess, unpack what our allied health service could look like under the AN-ACC model, it was, I guess, a more broad thinking around allied health services into the future, but then it quickly moved to that pain management question. And like you said before, the prescriptive nature of pain management that we have in place at the moment under ACFE, I guess the removal of that prescriptive nature and thinking about that and what does that mean for our business. So, not only from a resident perspective and what impact that may have on them, but then, commercially as well, what sort of impact would that have by removing that, that requirement? And so, lots of questions around the pain management programs, commercial viability, and I guess initially a lot of uncertainty in amongst all of that. But as we've kind of moved along, I guess, our AN-ACC journey, if you will, we're starting to, I guess, find a lot more comfort in where we're headed with it all. And I think, like you said before, there's almost a level of excitement and some opportunity in amongst all of this to be really, be able to offer our residents a much better service and much better allied health service for sure.
That's a great point of view, Dean. I think that excitement element is a good message to the sector, because I think definitely hearing a lot of those concerns and hearing what that reaction is quite settling. Andreas, go to you next.
Thanks, Rob. So yeah, I share Dean's opinion. So our first reaction was quite positive. We saw lots of opportunities moving from a very prescriptive and regulated 4B program into something more that we could offer to residents. So something driven by consumer-directed care and functional enablement programs, which we have been doing for over 12 months, and we're quite excited about them. So we're still in the process. We are, like Dean, just learning and calibrating, but we also feel a lot more ready than 12 months ago.
No, that's great. That's great. And we'll hear a little bit more about some of the activities you're going through. Sonia, to you.
Well, our first reaction was, oh my goodness, where do we start? Where do we go from here? lot of mixed feelings. Like Dean and Andreas was saying, it's great for person-centered care. It would be something that our consumers will benefit a lot. But then again, there are a lot of questions around whom do we need to have these conversations with? Where can we find more information about this? It's about the approach and planning and funding. What the impact is this going to have on our consumers, on our staff, and on overall funding for the company? So what are the costs that are going to be involved? Are the costs going to be higher, and so on?
No, great points on that, Sonia. Siobhan, we'll head it to you just to round out on some of the last areas of this topic. Oh, sorry, Siobhan, you're just on mute.
Is that better?
That's perfect. Thanks.
Okay.
Siobhan.
Hi, everybody. I looked at it from a then and now, a how and a who perspective. So then was the shock with the new process and how we were all very much left in the dark and we were drip fed tiny little pieces. It was like the provider wasn't entitled to know what was going on, and it made us all quite nervous. Then we learned that the pain management plan and programs would no longer be funded, and that caused another ripple of concern across organizations, and I feel we wouldn't be alone with that, feeling how this was going to impact us moving forward. Our current pain management program, we deliver 92 rotating 4B plans across the organization. We have 70 4As and about 200 3s. So that makes up a significant portion of funding for us. And when we had a look at how we would be moving forward, so many of our residents who were now classified as a high, there was no classification in the compounding factor section. So lastly, we worried about would we have time? We had time. Would we have time? We have time. So it was this kind of seesaw. How are we going to get there? Now there's a growing sense of urgency, I feel, with October 1 possibly looming. And again, we're left in the dark. We don't know if this is an actual day of launch or not. So we feel we're going to be able to sustain the costs moving forward. But what we need to make sure for us and what we worry about is, will we be able to maintain that same level of interaction and care for the pain management program? And will the residents have the same satisfaction with what we're able to offer moving forward? And will the alternate pain management program meet the needs, the regulatory compliance? And then it's the how, like, how are we going to deliver it? What level of process are we going to give to the different classes of the new AN-ACC residents? And then I think the last big thing for us was well, the who is going to do all of this? It's a little bit outside the ACFI bag now, isn't it? Because it moves away from us a bit more to the physiotherapist, the occupational therapist, the physio assistants to coordinate. And where on earth are we going to get these people given today's climate? It's so hard to source out staff for aged care. So that's where we're at.
And you were touching on, I think, what was on the minds of a lot of the panel and the audience, also about the 200 minutes and how the Allied Health does not include that provision in direct care at the moment. So certainly those those sentiments are definitely shared amongst the sector with that. But I think this is a good opportunity for to give a little bit of context then of what we're seeing providers such as yourself and those journeys they're going on to really approach these programs and start to build what it will become the future and the new pain management and well-being offerings post-ACFI. And just to give that sentiment again, this is really an opportunity for the sector to really shape the type of pain services without those prescriptive specifics that we are so familiar with and think about within the 3, 4A, 4B context, and all the record keeping that needs to be then met in order to sustain the funding through validations and the audits that all of you would be managing across your services. But it's also up to us to, as a sector, to consider these and really design these new consumer-led outcomes as the panel has really started with. So really, we put this into a 3-step transition process, which we've observed that a lot of the providers starting to work on. And some providers have started this journey at the beginning of this year. Some are just starting now. I guess the good news in all of this is by starting now, as the key takeaway, means that you do have plenty of time to calibrate, to really get feedback, to not take a big bang approach and look at that incremental changes, which we'll get into discussion next across the panel. But really step one we're finding that providers are going through is to start with creating those new and those alternative pathways. And with that, what I refer to that is, in order to, I guess, deconstruct over a decade of what Tyler was sharing of 60% of the sector now having a 4B claim in Medicare, as well as the 4As and the 3s, those processes do take time to unravel and to bring the consumers, their families, and the wider stakeholders also on that journey. Because if you are changing things, these are all stakeholders you would need to engage with. So as a first step of designing those pathways out of the programs, a couple of the design tips that the sector has, that we've been observing, is that make them consumer-led. Engage with the consumers, engage with the wider workforce or the teams, such as your lifestyle, your physios, your OTs, as Siobhan was referring to really get them to help shape that those new offerings that are coming from the base or coming from your services. And as a result of that, most of you would also be going through the Safety Quality Commission's new consumer engagement surveys. So, by undertaking this and actually engaging at the time when you're going to have portions of your residents and family member representatives being interviewed, we're also finding that is getting better results in some of those survey responses as you are engaging and helping, the consumers shape really the new services of these organizations. I think the other tip that I wanted to share that we've been observing across those providers is that this is also an opportunity to differentiate your services, maybe to an area. If you are a specific provider that focuses on maybe a specific culture of type of residents or specific needs, dementia specific, you may have different pathways and programs than a typical, low care or aging in place provider. So really, it is an opportunity to make your services quite unique around these offerings to really add an element of differentiation of how, your programs are aligned to the individual specific needs of your residents. An example of that would be things like walking for Parkinson's warriors. That was a concept that came up to really, focus on a cohort of residents in our care, and certainly a member or family who does have a relative or a family member that is seeking care that has Parkinson's. These are the elements that may really resonate with them and stand out as to why your service is quite unique for the condition that their family member has. So really take that in consideration when you think about those designs across your services. Step two is now bringing that process and those pathways into more of a quality and check around now the process that you'll have to define. So again, as Siobhan noted out, you first then want to now start to approve those offerings with your quality teams, the allied health teams, the individuals that will need to be comfortable with how and will our accreditation principles be appropriate, and will we sign off on that so that we can then start to commence them and roll them out. So as you then start to land on those pathways and now start to really put the element of compliance and that process embedded, a couple of the design insights and tips that have come out of previous groups that are going through this is that certainly review those processes to ensure that it's not going to expose you to any of those accreditation gaps or associated risks, as well as any of the current ACFE assessment risks, because we do have to run ACFE all the way through until October 1st, or if there is a slight delay with some of the legislation hearings that need to be met, we're being informed that it wouldn't go past November, but certainly there may be a week or two in there, but it just means we still have to be ready to continue to claim ACFE up until when the last residents come through, which means you just will get those last couple of days funded for before then it all converts to AN-ACC. But the other elements of that too is to then start to also consider if you are going to bring in new personnel to this process, such as lifestyle teams or activity officers to maybe run more group therapy or programs, which may have social elements like games that include range of motion and gentle exercise activities. We need to also consider competencies and what we should be also looking after for organization and the residents, because what may make sense to you as a physio or an RN or a clinician within your service may not be assumed by every one of the personnel because of their background and further education around specifics of this nature. And certainly one of the last areas too is make this goal oriented, have something that can be measurable, set a target. But again, by starting now, you have that benefit of time to really explore and calibrate and review this process to make sure that these are embedded in a well and safe way. And really the final step of the program that we wanted to suggest to the sector is really then, as you commence those residents into those new pathways, make it an iterative process. Don't try to take the big bang approach. And again, to the point of starting now with having that added bonus of the time, we also have, again, with the departments not mandating the care minutes, we have another full year of this to really work out and also work out what type of staff personnel that may be also considered under the direct care requirements under some of the specific fact sheets of AN-ACC. They can also be included to take on some of these activities. But these are things that we can now start to explore, and we have the benefit of time before October of 2023, when then the care minutes becomes a mandated outcome for the sector. But also the approaches and how you do this is also very important. So certainly collaboration as you migrate those residents off and use that multidisciplinary teams to really explore the consumer's needs, such as a case conference with the allied health team, the care manager, and even a consumer or the consumer representative to really understand what the the resident and that stakeholder group need. And an insight that we found with some of the programs that actually started this already, and we're unpacking some of the 4B clinics across their organization, they found that nearly 20% of the residents that they approached in this case conference actually voluntarily wanted to come out, but they loved the interaction. They didn't want to hurt the feelings of the personnel that they were used to interacting, but they were feeling that they wanted more of the time back so they could spend with their families, to spend on other activities, and especially coming out of some of the COVID lockdowns and some of the restrictions that some services have been going through. So that was a really interesting insight that nearly upwards of a quarter of the residents were voluntary, just wanted to come out and actually did not seek any formal alternative to what they had been in place for sometimes years in their service. And then finally, the review of this information post the change. So certainly as an accreditation outcome, the quality teams, once we design those processes, looking at how those documentation of this evidence is followed. If we are taking residents out, is that process being followed by the staff? Can we audit that in our care management system? What are the gaps? And making sure then that we are continually educating and informing those that as we change these things, we need to ensure we are still held to the accreditation principles and a lot of those indicators that would indicate good quality outcomes for your accreditation processes. So as an evolution though, keep evolving, the thinking, this is a starting point. And those 3 steps will, enable you and your services to, start to consider what these new offerings that the panel had suggested. And we'll go back to the panel now to really explore some of these, but some of the great questions that, can evolve from these is, firstly, once we define, some of the base services for the typical pain management, well, now we can think about what is above and beyond, so ask yourself questions, what can we charge for these above and beyond, offerings that may now take on more elements of, well-being and wellness and lifestyle type of, activities for the residents. Certainly also ask your questions about how can we differentiate these offerings amongst others in the sector, but also others amongst what the resident cohorts that we provide care for. So an example of if you have a high portion of dementia residents, some of these programs may look very different. They may include more cognitive support outcomes for pain management. And certainly then, we want to also consider how can we include other team members, and coming back to the new requirements of direct care time inclusions. This is an opportunity also to see how we can incorporate some of those wider personnel that do fit under the definition of direct care time to help you also achieve the 200-minute averages of the case mix distributions that you'll be seeing within the AN-ACC classes that are now coming and going within your services. But some of those design tips too, to note on is that if we start then with those key steps, then you can start really assigning what you feel is the base level offering for just what the Aged Care Act and what we must, provide, which will help you then, envision and become more creative with those alternative offerings that are now, outside of the standard pain management that we must provide to all consumers in our care. And with all of that, I wanted to then push back to the panel now again, and also to just hear from them on their journeys and really how are you guys approaching this, and what are you doing and what are you up to? Because a lot of the audience on the call today and those who will be listening will be having the same question and are also looking for relative barometer of where we're at, and are we too far behind, or is there time to catch up? So certainly giving that sense. So maybe I'll start with you, Siobhan, and we'll go in reverse. How's Peninsula Village approaching this in this design and the engagement of these programs outside of the ACC? And just make sure I get you off of mute here.
Yep, back. So we have undertaken some things. So what have we done so far? So far, we've done a cost analysis on what our current pain management program costs us. So then we have a baseline and we know what to work backwards from. We have presented a planned prospective cost with our forecasted new ideas to the board. We've introduced spa treatments for our bedbound residents. So that's a 2-person procedure, and that's been very successful, and a lot of care minutes involved in that. We have introduced Groove in the Move for our dementia residents, as you said, looking at something new for those residents suffering from dementia. It's very interactive with music and movement.
Oh, excellent.
We've established a steering committee with wellness and hopefully with our well-being to see if we can provide a collaborative approach to pain management. We've attended all of our AN-ACC assessments, which is very, very important to give us pertinent information on the residents' current pain. And what we hope to do with that is analyze our residents moving forward, segregate who has pain only, who is using our pain management program as a source to help them with mobility and strength, because they do actually do that, and also to determine and segregate out who's actually using our program just for emotional and tactile interactions, like the people who've been on it since 2017 endlessly, you know.
Yeah.
We've also introduced education on the documentation, and we've been doing that for some months, keeping AN-ACC education in mind. We've devised a rotational documentation system to try and capture the correct wording and terminology moving forward, keeping in mind ACFE and AN-ACC. And what we plan to do is take a big breath and not panic as much as possible. We're going to continue to deliver our 3, our 4As and 4Bs until we actually get a D-Day for launch, because there's no point in cutting off your nose to spite your face, because our 4B is provided by an external provider and we're very comfortable using them and we're very happy. We want to make sure we're incorporating the mandatory staff minutes with our new plan moving forward. So looking at engaging occupational therapists, physiotherapists, and possibly doubling our physio assistants for individual classes and exercise programs. And we feel we need to offer a tiered level of migration. So depending on the class and depending on the residents' mobility, would probably help us guide to how much interventions and what sort of interventions we need to migrate them across. So we'd have maybe immobile, like a level 3 for immobile residents, a level 2 for assisted mobility, and then a level 1 for mobile residents. And looking at aromatherapy and application of creams, ongoing use of TENS and hot packs. So lots of ideas, very, very exciting. So I still feel we just need that end date before we again, we're in that flux, aren't we? So we need that date, and then we need to gradually and slowly and carefully and clinically manage our residents with pain and make sure their needs are met moving forward.
Oh, that's excellent. A lot of great insights there, Siobhan, and certainly ones that I'll have some follow-up questions for the panel. But I'll get to Sonia now next, just to give a bit of context as to where BASI's up to with this program as well.
So for us here at BASI, we've got a structured team approach that puts the consumer in the center of the planning. We've involved all the teams across the board, from finances to HR, quality, residential managers, lifestyle, allied health. We have contract with, and of course, our ACFE team. Our HR has done a bit of a work with our consumers, getting them to voice their sort of preferences and provide us with their own feedback as to what would they like to see happen. What would they like to have at the facility as means of managing their pain? Then we were looking at whether the consumers are still within the ACFE appraisal period or not. We are looking at the level of their cognition, seeing if we can make that transition smoother, seeing whatever their cognitive level is, and perhaps seeing if we need to implement some cognitive therapies or some well-being clinic. Also, we are considering the reviews, assessments, care plans, proper documentation. So for accreditation purposes, there is that trail to show that we have examine our consumers properly, see what their level of pain is, and use the best approach to address that pain. So we're using the pain check, and we're just observing our consumers, seeing what works, what doesn't work. Our allied health professionals have come up with a couple of lists. One list is a suggestion of a standard sort of interventions and programs that we could offer to our consumers, and the other lists are additional interventions. Those additional interventions, if consumers choose to have, could come at the additional cost. We do realize that what works for one site may not necessarily work for all of the sites. So we are taking that in consideration. We are reviewing the roles. We are attempting to create a multi-roles. We are reviewing the contracts with our allied health professionals, and just seeing the design of the program, and as well as the delivery. We are also looking at what are we going to do with the new consumers that are coming into our care from this point in time onwards. We are looking at reviewing our current policies and procedures so they are in line with all of the AN-ACC changes. Again, we are aware of the challenges. Some consumers may not want to give up the 4B. The time and of course the funding. Is it going to cost us more? How is it going to be funded, and all the rest of it? So just basically overall working on it as if when we get more information from the Department of Health, we just work on it and see where do we go from there. 1st of October is only the beginning, like you said, it's not the end. So it's going to be a ongoing process, and it's going to require a continuous improvement.
Absolutely. And it sounds like with that, a lot of great initiatives in there, and even putting attention to even how technology can help standardize some of the processes of, your pain assessments. I heard pain check and some of those other elements of, those outcomes. So that's excellent. Andreas.
Thank you. So I'm going to try not to repeat what everyone has said, because I feel like we are all on the same boat. So yes, we went through the same. It was a very multifactorial, multidisciplinary process. And at the end, we wanted to balance the business and the clinical outcomes, because for us, it was very important to put the resident at the center of the process, but also to consider all the outcomes that we can have flowing from there, from accreditation, ACFI validation, ACFI uplifts, even timelines are very important. So we actually started quite early, about 12 months ago or more, with the support of Rob and a group of other providers that we work with. And we went through the steps that the other panelists have described. So a commercial analysis, a clinical review, a service review, and a workforce skill mix. What has come out at the end of all this is 12 months of a very beautiful program where we moved away from a deficits-based, boring 4B 80 minutes for everyone, doesn't matter what you have and what you feel like, into a more flexible, holistic program. So we have different services that range from cognitive enablement programs to functionality enablement, false smart, and also, of course, pain management. So our rate of discharging residents from a full 4B has been really variable depending on residents' choice, next of kin choice, and clinical best practice, because we want to make sure the process is safe for the resident and for the organization as well. And like I said, at the center of all this has also been, let's take it easy, let's take it step by step, because at the end of the day, we have to consider it is a clinical process. It is a clinical treatment, and we can change modalities, we can change services, but it has to be driven by consumer-directed care, which is what AN-ACC is encouraging us to do. And a final point I wanted to say as well is it's been very positive for us in terms of and marketing, consumer satisfaction, like Rob mentioned, is something more the residents have, is really a benefit for them that has come at no extra cost, because they used to have 4B massages and they're great. However, when you have been receiving them for over 6-12 months, you do need something else. And now they have exercise groups, they have group therapies, they have individual therapies. We have now even been introducing slowly different range of new modalities that are very important for a new age of aged care residents, that like acupuncture and reflexology and all these alternative therapies that are very important for them. So we saw an opportunity to integrate different teams, integrate different resources into creating something for the benefit of the resident, for that functionality, and at the same time use it as an AN-ACC process where we are reviewing our residents for any AN-ACC change in terms of care needs or classes. Yeah, it's been very positive also in terms of clinical outcomes. Some of our facilities have been audited by the accreditation agency and they loved the program. We are tracking clinical metrics. We have seen a significant decrease on regular falls on the average resident, at least on 40% plus. Some facilities have, the average fall has dropped 60-70%. So yeah, fantastic outcomes. Great resident satisfaction and great engagement from allied health teams, because now they have this diverse range of therapies that they can offer and the residents can enjoy. Thank you.
That's what it's all about, isn't it? So that's great. Great to hear all of those initiatives and the positive outcomes from decreasing the falls and other elements that certainly I know the Safety Quality Commission is also looking at as part of their ongoing accreditation and unannounced visit reviews. Dean, what are you to give your update for Catholic healthcare?
Yeah, so a little bit like Andreas, I'll try not to repeat what everybody else has said, but it's nice to hear that I guess we're all kind of aligned in our approach, specifically about it being resident led. But like most providers, us at Catholic Healthcare, we've been analysing our shadow assessment data. So really pulling as much data together as possible to not only analyse it, what impact it's potentially going to have to our business. From a commercial perspective, but also in terms of the case mix classifications for our residents. So at the individual resident level, what does that look like? And then obviously per home, what does that look like across our 43 homes at Catholic Healthcare? And so with those case mix classifications in mind, obviously with the allied health provider focus, what we've been doing is really working with our allied health providers to ascertain what it is actually that the residents need. So is it, like you've heard, is it that they still need ongoing pain management? Is it that they need some one-on-one therapies to, for re-enablement? Is it that they need some, falls prevention groups or exercise groups, or just some maintenance physioactivity or allied health interventions? And so, through partnering with our allied health providers, we've started to build a profile for each home about, okay, what it is that those residents need. And we've asked our allied health providers to kind of wrap their service offering around that and bring it back to us in the form of a proposal. And it's been a really interesting exercise because we work with a number of allied health providers. And what we've seen is that their approach to AN-ACC, I guess across the spectrum, is very similar. So we take a lot of comfort out of that at Catholic Healthcare because we can get a really consistent offering across our group now. And I guess to tap into what you said earlier, Rob, to really turn that into a service offering at Catholic Healthcare that'll be a little bit of a differentiation from the industry. We've got a fairly diverse portfolio at Catholic Healthcare, and we really think there's some huge opportunity in all of that. So so look, we're also looking into all the possibilities. We're taking it as it comes, and we haven't sort of jumped in as far as Andreas yet, but certainly we've got our model in mind, and we're comfortable that the providers that we work with will be able to continue to move forward. So.
No, exactly.
Rob, just to give a bit of voice to the attendees, we've got quite a lively discussion happening, which is great to see. And I think what's really been resonating with a lot of people active in the chat is that we are now free to explore those alternative care methodologies, making it more consumer directed, not being pinned down to a very specific application of physiotherapy directed massage. And I think with that, there's probably, another vantage point or another way to view that, in that if there is under AN-ACC no legislated requirement to provide allied health, and there is no specific claim to derive funding by using allied health, is that going to mean that providers will all of a sudden remove any sort of reliance on OTs, physios, and that sort of thing? And I think that goes back to what I was talking about initially, where we kind of need to unwind that thinking, where we have quality standards and we have resident care needs that still need to be met. We still have the liabilities of these activities, which would require a registered allied health professional to deliver. And so I think, most of the group that's chatting away certainly resonates that we can explore those alternative methodologies. But on the other side, just some concern that without having that very prescribed requirement for allied health, and it's also been raised that they won't be included in the care minute requirement, that could open up some liabilities for providers. So I think, good discussion, and probably just some more thinking required around how we approach AN-ACC classifications and where funding is derived, where the care that's required today will still be required tomorrow, and the funding that's provided today will actually be more tomorrow. So, but yeah, great discussion happening in the chat.
No, it's great points. And I think, for the panel here, a lot of you do use outsourced or contracted allied health groups. Maybe just a question to you in general around that sentiment piece that Tyler was referring to. How have you found that engagements with those allied health contractors? How have you worked with them to really, I guess, move past what I think the initial reaction a lot of us had was that there's no pain management in this new model. There's no funding, there's no outcomes. And that's a big diversion from where we started with, even going back to, RCS days and how things were funded. So now, being released, how have those conversations gone? Maybe throw to you, Dean, first, just give me a little bit of a sense of your discussions.
Yeah, look, I think our experience has been really positive with our allied health partners. I think we're in a position now where we've got such large, like you said, almost 60% of residents across the industry are on some sort of pain management program, generally run by an allied health professional. And just with the workforce the way it is at the moment, it's really tough for the allied health providers to find those therapists to keep showing up for us every day amongst everything that's going on, and COVID and AN-ACC, all the rest of it. So I think, from our perspective, it's been positive because, most of our providers are seeing on the horizon potentially a reduction into the hours that they're currently, contracted to service the industry. But in that, they can also find some efficiencies, because from a large perspective across the industry, is that what we find is the allied health providers just don't have the staff to be able to service all the 4Bs across the industry. So there's some efficiencies there for them. And I think, we share in the excitement around being able to really offer our residents, something better than what they're receiving at the moment.
No, it's great. And Andreas, I know you have your similar allied health partners as well. How's that journey been, and those conversations been working with those teams across your services?
Oh, it's been very positive and very engaging, because we early on identified that there was a shared challenge. We both had to partner up and come up with an idea that will benefit their teams and all this large workforce. Our pain management program is very robust in our organization. and therefore the workforce is large. And we've always seen them as partners. And I believe that the role of the physio and OT is just essential, because it just leaks into so many aspects of the business, like regulation and consumer expectation and clinical responsibility. At the end of the day, physios are the main decision makers in terms of mobility, and mobility is your ACFI and AN-ACC main driver. So I think it's only smart to keep your allied health services running, and it's only also even smarter to try to strengthen them, because we shouldn't be scared. At the end of the day, it can be cost effective. It just needs to be flexible, and that's what we all going to have to do in the next 12 months. Be more flexible.
Yeah, flexible we are, aren't we? We're used to that. Now, Sonia, I think you have a bit of a hybrid. You've got some external and internal allied health, or are you completely in an outsourced or a contracted relationship with most of your services?
I was contracted only, but at the beginning there was a bit of uncertainty, there was a bit of a confusion, and there was a bit of a conversations to be had, just to provide that reassurance and build that confidence, and again rebuild that report. And we reached the point that it's now become a positive sort of experience, because now our allied health professionals are very excited at the prospect of being able to provide variety of different programs, because as we know, not everybody likes to be touched. They would like their pain to be addressed in so many different ways. And we still need to have our allied health professionals delivering that functional physio, and perhaps work around the enablement programs. So put something in place that'll enable our consumers to be the best that they can, because we know that's rewarded now under AN-ACC as opposed to being punished for it under ACFI. So it's just giving them an opportunity to come up and design different programs that'll benefit our consumers. And again, they've put a lot of thought into designing a program based on what consumers' preferences are and what consumers say they would like to see happen. So it is now a positive sort of interaction. Yeah.
Oh, that's great feedback on that. And I think, Siobhan, you had quite a variety of enablement programs, social programs, and also across a multidisciplinary team, which I heard lifestyle being in there, you had activities and so forth. Yeah, how did that play out with the teams? Who was really core to coming up with those areas? Was that a partnership with you and the allied health teams, or did you open that a bit wider to really think about those programs more holistically across Peninsula Village?
Yes, we were in a very lucky spot that we had a 5-day strategic planning with the organization. So how we plan to move forward with AN-ACC was a significant component to our financial viability moving over the next 3 years. And so it was a collaborative approach on how we are going to move forward. We have a combination of internal and external allied health providers. So our internal providers, we feel, will continue as the same, and our external provider will. It's a status quo at the moment. So that's, I think, my executive care manager has been liaising with them with regards to how we're going to move forward. But it's going to be definitely a gentle reduction for the benefit of our residents. So for us, we still haven't got a clear path with our external providers, but our internal providers, I think the hours will definitely be increased. And again, the excitement with the varied approaches that we're going to be able to offer our residents. And like Sonia said, some residents actually don't even want to be touched. They just can't stand it. So we have to get more creative and offer a more diverse menu of opportunities to cater for their needs.
No, that's excellent. And I think that's just great messages all around on the journey that you've already have gone through, and a lot of the the positive outcomes that is really coming from this compared to I think where we all started when we started to really digest what was in the AN-ACC instruments and jump into some of those conclusions and fear side of it of what it could lead to. But certainly great messages across your organizations. Well, I just wanted to inform everyone, unfortunately, we're out of time for today, but please stay tuned and register for our next webinar where we'll pick up some of these aspects too as we think about the future viability of these services, but also specific to your care minute time. So we did touch on elements of that today, but we'll go into that on the July 28th. So same time as part of the AN-ACC in Action series. So please register and join us for a continued discussion on how that is taking shape across the sector. And further, we'll be launching next month officially. The ACC calculator will now be changing to the AN-ACC calculator for the ongoing and education components of this instrument. So certainly a lot of knowledge and a lot of retraining for those AN-ACC coordinators or case mix managers. These are some of the roles which providers are starting to redefine for those personnel that will be in charge of really defining a data set of forecasted AN-ACC classes so that you can better manage and also be in control of that changing distribution of the case mixes and classes as residents change in your services and in care. So that will be available through the website as well as on your iOS, Apple, and Android devices in July. So please stay tuned to that. And last of all, please keep up to date with any of the latest blogs and feedback that we have. So thank you for all the comments today. We'll put those into more of a structured content through the AN-ACC Resource Hub. Those questions, those items we'll continue to explore and unpack and get additional items addressed as we work through this reform change across the sector. Thank you again to all of our panelists for joining us today. Great insights, great feedback, and I believe everyone on the call has certainly enjoyed their time and hearing the sentiment and your experiences that you're going through. And I, as one, speak for myself, definitely loving hearing the positive outcomes this is also shaping for the consumers and for those families that are are going to be with you through this journey, but also the residents that will be with us ahead when all of this will now be changed. So thank you again, and we'll join you in the next session. And please keep doing what you do. Be well, stay safe, and we'll speak to you soon. Bye, all.